just this morning. So we started late and we finished late. My name is Major Hart, and I will be teaching you guys PHARM Block 1 and Block 2, or Semester 1 and Semester 2. I will be this semester teaching typically you all from 10 to 12 and then them from 13 to 1500. So if you need me, it'll probably be before or after because I'm going to actually try to eat lunch this semester. Typically I don't, but I'm trying to start to eat. So usually my lunchtime, I'm going to try to take my lunchtime, okay? I am always available to you all. I'm going to try to make PHARM fun. I know y'all probably heard so many wonderful things, but I'm trying to go through the course, fix the course. Please pay attention in class. You get sleepy, just stand up, I understand. Again, with the questions and my availability, I'm typically available to you. Also, if you, I prefer that y'all use my cell phone because sometimes I may not have my laptop with me or I'm moving around somewhere. So if you have a question about something and or it's not clear, just let me know. Also though, what I do expect is that you're trying, right? So you reached out to somebody, they couldn't explain it in your study group, or you're like, hey, I looked it up, I don't understand, can you explain it to me in a different way? I'm more than happy to help. But if it's something that we talked about here that's like, yeah, I have people, oh yeah, I was studying something else and so I just didn't hear it. Like, I'm not gonna reteach it, okay? So, that is my disclaimer on I am always available for you. You'll see different TLOs listed. ELOs are your TLO is essentially that you're gonna learn how to take care of your patient. I'm not gonna make you diagnose. So I will tell you what is wrong with your patient on your exams and you're gonna say, oh, this is the medication that we use. So typically for PHARM 1, a lot of the things that we're gonna be looking at is like, all right, how does this drug work? What drug class is it? What are the big side effects that are happening? Like it's not as complex, the questions aren't as complex as what you're gonna see whenever we're looking at PHARM 2, okay? So that's the big kind of difference between the two. So you'll see your ELOs that are gonna be listed on the beginning of each slide deck. I'll try to get practice questions for you. Reviews, I haven't decided if I'm going to do a review yet or not this semester because I get mixed reviews on reviews and it's made it to where it's not enjoyable. So I will let you know if we will do a review or not. I'll probably just ask you guys questions throughout or post up questions that are like practice questions or review questions for you to kind of focus your study a little bit more if we don't do like a class review. So it might be a mixture of both throughout the semester. Jeopardy games, things like that. ELOs, I told you again, you'll see those on every slide deck. And then your goal, ultimately, you're gonna have a lot of power when you're done with this program, right? You're gonna be able to diagnose patients. You're gonna be able to have access to several different thousands of drugs. We're not gonna be able to go over every single drug that you may have the ability to prescribe, but I want you to know how to find information. I want you to know how to be able to understand simple pharmacotherapy, to be able to say like, all right, how do I go about prescribing something, or how do I avoid this med if I know that this isn't gonna be a good thing for the patient. I understand that several different people have several backgrounds, right? Like there's a lot of us in the classroom. Some people have a medical background, some people don't. So if I'm using a term and you don't understand, then let me know, because I've been a pharmacist for almost a long time, okay? So a lot of the things that I say may seem like it's basic or common to me, but it's not common to you. And I try to catch it and I try to make sure that I define it. But if you don't know something, just say, hey, raise your hand, save space, and just say, I don't understand. Or what does that abbreviation mean, okay? Because if you don't know and then we get to the exam and you ask me, I'm not going to be able to answer it, all right? So ultimately, I just want you to be able to understand medicine. How are you going to prescribe medicine? When are you going to avoid certain medications? How can I help a patient? And the other thing is, I'm a pharmacist who doesn't really love to just throw people on medication, right? You put somebody on a medication, make sure that you're having them actually do lifestyle modifications as well. The medication isn't the only thing that we try to give a person. We try to make them fix the underlying issue if we can. Sometimes we can't, okay? And if you put somebody on something, remember you might need to take them off of it, all right? So don't just throw people on meds and leave them there. Sometimes you gotta go back and revisit and be like, oh, okay, maybe I need to take you off of this now, all right? Your study materials, so your exams will come strictly from the PowerPoint. If there's something that is not on the PowerPoint and I say it 1,000 times, that might be a hint that you need to write it, or I will tell you to write it onto your PowerPoint. But that very rarely happens. All of your material is gonna come through your PowerPoint lectures. There is an assigned text. I built the PowerPoints off of that, so you don't need to read anything that's on there. Those links that give you all those suggested readings, you don't need to look at any of that. If you use your PowerPoints, you should be okay. I will also try to, again, give you some of those practice questions that I talked about. And then you have already on there a calculations notes, like kind of handout that I put for you to practice different calculations and work out. It has the answers to that as well. When we talk about calculations, there will be 2 calculation problems on every exam you have in PHARM moving forward, okay? So just kind of keep that in the back of your head as well. Exams, same things that we have in every other class. You have to make, I don't know why I said 75, a 76 or above, right? But your class average needs to be above a 75. Again, those 2 questions, there will be 2 math questions on every exam. Your first exam is going to have more than 2 math questions because we're actually going to teach you calculations, so you'll have more than 2 questions on that. Your generic names are going to be what you're tested on, not the brand, but when I give you exams, I write the brand in parentheses for you, because when you go out to phase 2 or in practice, or when your patients come in from the commercials that they saw, they're going to come in, they're going to tell you probably the brand name. I don't expect for you to remember them. I'm just putting it there so like it's osmosis and you have like some, oh, I remember, I saw that drug. I saw that name before, bless you. So that's why it's there, okay? But don't memorize brand names unless you're using it as like a mnemonic to kind of study something. I'm expecting for you to know the generics. And then again, I already told you about diagnosing and all that stuff. You're not going to be able to, I don't need you to know that. I don't need you to know lab values. I will tell you if it's high or not on the exams, not expecting for you to remember that either. This used to be a course with 3 exams. I changed it to having 4 so that the information is kind of spread out a little bit better for you, and so that you have a better opportunity to pass the class, because if you fail one, it kind of makes it a little bit difficult. The only difference is your exam 4 is going to be moved now to exam 2. Okay, so we'll go over in our next block is going to be antimicrobials, antibiotics, things like that. That's the only difference. So then this will all just shift, okay? We're trying to see if this works with aligning better with other classes. Okay, same exact material, same everything. It's just now going to be your exam 2 information. PHARM 2, we'll worry about that when we get there. But again, 4 exams, you have different content in each one of those exams as well. And then just some quick study tips. So when you're looking at how to study for a PHARM, I'm not going to like sugarcoat it and tell you like this is an easy class. It's not an easy class, right? Because it's a lot of drugs and it's a lot of memorization. And a lot of it is just that. It's like you're just memorizing it. Try to come up with mnemonics. Try to form those study groups if you can. But this is a lot of just how can you organize the information to remember it is the name of this game for this class. It's not like a lot of your other classes. The exams don't have like a lot of pictures or any of that stuff on it. Like it's straight like, here's this drug, what does it do? Here's this drug, what's the side effect for it? So when you're doing it, you can study, there's lots of different ways. I've seen some people do it this way. So they'll have like the disease state and then they'll have the drug class. So the disease state would be like, oh, I have hypertension. And then they'll have a drug class. So let's say for hypertension, one of my drug classes might be a thiazide. And so I would have drug class thiazide. And then I would write my mechanism of how those work. I would write my AE means adverse effects or like a side effect that they may have. Sorry, an MOA is mechanism of action, which is how it works. And then your AE would be like the adverse effect, like what are the side effects? What could happen to me if I take this drug? a contraindication or CI, that means like if there is something wrong, like I have a sulfa allergy, then it is contraindicated for me to take this medication. Or if I'm G6PD deficient, it is contraindicated for me to take a certain medication, okay? There's something that makes me not be able to take a medication is what your contraindication is. And then DDI is a drug-to-drug interaction. So an example of that would be like I'm on drug A, and if I add drug B to it, now my blood pressure might drop very, very low. Okay, so I don't take these two things together. So there's a drug-to-drug interaction. We'll also have interactions that you see with food, where like you can't eat certain foods when you're on certain meds, so that's a drug to, we still classify it as drug-to-drug interaction, but it's really like a drug and food interaction, right? Where I can't take these together. So you'll see where some people will set up their study material this way, so that they can remember the drugs, remember the big ideas, and then when you have the little things, right, that are like, when we talk about a class, you may see that all of these things kind of fall under, they'll have a very similar mechanism of action. Then you want to go in and you want to pick out the things that are different about a certain drug, right? You'll be like, okay, all of them do this, but this one may do this, and this one has this little weird thing, and this one has this. Most drugs are going to say that they make your stomach upset. Most are going to say that they have headache. That is not going to be a question on your exam. I'm not going to ask you the ones that like everything does, unless you see where it has like a huge percentage where it says like 80% of people are going to present with a headache. Okay, I need you to remember that so that you can tell your patient that, okay? So when we talk about adverse effects, there's lots and lots and lots of them. I will focus on certain ones and let you know kind of where to focus your studying at. This is another thing that I've seen some students do on how they kind of classify or study for their meds. They'll have a classification, MOA, the uses, so like what are the different disease states that I can use that medication in, your adverse effects, interactions, and then different subclasses within the drug class. So these are beta-adrenergic blockers, but I have several different things that are classified as beta-adrenergic blockers. So what you see here is I have my non-selective, I have selective, and then I have my intrinsic sympathomimetic, or ISA beta blockers. Okay, so you can have subclasses. There are some where there are not any subclasses. Okay, so it just depends on what works for you is what you're trying to figure out as you're going through. I will tell you that this first exam is very word heavy and like just basics of PHARM. There's only sympathetic nervous system and the parasympathetic nervous system that have like a lot of the drugs on them. So I usually tell people to try to do very, very well on this first exam so that you have cushion for everything else that kind of comes after. Okay? So do not wait to study. Look at it every single day, even if it's for 10 to 20 minutes. I typically tell people 30 minutes, right? Every day to just look over it. If you can look over stuff before class, look over it before class. I know y'all are busy. I got it. I went through pharmacy school and it was rough. We had 3 exams a week. So I understand and I sympathize. But when you get done, it's gonna be great, okay? So try to look over it as much as you can, okay? Because sometimes stuff will be in your head and you won't even know that you learned it, okay? So be prepared. Talk to you already about reviewing. Make sure that you look at the slides ahead of time if you can. Study groups. This is if you are a study group person. Everybody does not have to be in a study group. I was not a study group girl. Study group made me nervous. I was like, oh my gosh, I didn't know the answer to that. And then I was fine, okay? So, you can try it. This is not just see what works for you. I'm not telling you that this is meaning that you're going to get an A. If you listen in class, you don't have to watch supplemental videos. You don't have to do anything extra. If it is not clear to you, then try to research a little bit more, but don't get very, very in the weeds. I'm not getting very, very in the weeds with you. I don't expect for you to be a pharmacist when you finish this. I expect for you to be able to pick up your mouth and say, all right, which drug am I clicking for this class? And be able to get to the right drug class and understand when you will be able to use something and when you will not be able to use it. Again, I told you about the memorization. It's a lot of it, okay? That is what you have to do for this class, and I'm sorry, I'm gonna try to make it as fun as I can, but it might not work, okay? And then ask around, you can't figure it out. Again, just ask me. This is what we talked about. And let me just make this clear. I don't want to scare everybody, but I want to set realistic expectations, right? Some people, this is a very easy class. And some people, they do perfectly fine because their brains work this way. Everybody's brain does not work this way, right? In like a PHARM way. Some people do excellent in other classes, and then they get in this class, and it's a different thing. It's a different science. But I don't think that it is anything for you to be afraid of. We are in here together. We will work together. If you fail an exam, do not wait until you fail several exams to come and talk to me. Because if I can help you study and if I can direct you better, I will. Okay? Do not wait. Do not feel like you can't talk to the person that's to the left, to the right of you, or in this classroom. Y'all should have a safe space with each other. Y'all seem very calm and quiet. Y'all don't need to be that calm and quiet. But we will work through it together, okay? Do not struggle and be by yourself, struggling, okay? If it doesn't make sense, then be like, hey, can somebody help? Because when it gets to the exam, we can't help, okay? I don't like that one. So, contact information. That's my office number. Don't call it because I don't know what happened while we were out. It's not working, my phone at all. So I have to open a ticket for that. That'll take probably until next semester. Text me. That is my personal phone number. Text anytime. If I'm awake, I will answer. I have 3 kids. I'm usually up doing something or waiting until they fall asleep so that I can work. So I'm usually around. You don't have to set up an appointment for office hours, but I am moving around a lot. So if you need to pin me down, text me so that you're telling me where I need to be, okay? My office is downstairs on this side and on the corner. So if you know where like Major Holzberg, Major Johnson, well, Lieutenant Colonel Johnson, where they are, then we're on that side. Yeah, no, yesterday. And didn't tell anybody. So now when y'all see him, be like, oh, hey, sir, big sir. So I'm over there if you do need anything, okay? All right, let's get started with our pharmacy admin lecture. And just so y'all know, I typically have my phone sitting up here. I'm not on my phone. I have a daughter, and she has brittle bone disease. So she's in school now, so if something happens, they have to call me, and we will get out of class immediately. I'm leaving y'all, just letting you know. But she has fractures, and so sometimes I'm making sure that everything is okay, but I'm not doing anything crazy. All right, so our PHARM admin and prescription writing. We're gonna go over this slide deck today, and then tomorrow we're gonna do calculations, and we'll finish this slide deck as well, okay? Tomorrow also I have my student who's gonna be with me, and so that's who's gonna help us go over calculations. I will also bring a printout because I know some people like printouts because they teach you, there's several different ways to do calculations, but I'm gonna teach you the easiest way and the way that I like, instead of like that long drawn out, like, I'm not even gonna talk to y'all about it, but I have a paper on the side for people who like to do like the dimensional analysis longer way, okay? So I'll have that for you tomorrow. Okay, ELOs, right? There's a lot of them. Essentially what we're talking about today is we're going to talk about what it's like to write a prescription, what it is like for us to report an adverse effect, what kind of resources can I use, what does the drug formulary look like, and like how do I know what to order, is this correct or not, the drug approval process, like how do the drugs get approved for me to even have them on the market for me to prescribe them. So this is like all of the things that we're going to go over. Again, on this block, your thing is going to be like familiarizing yourself with it's a lot of words. It's like the regulations of pharmacy and the foundation of pharmacy and what you're going to be doing, okay? So let's just start out with some what do you know things, some pre-questions. Who do you think is responsible for patient care? Y'all can talk. Everybody. The provider. Who is the provider? Are you the MD provider, the PA provider? Who's the provider? Whoever's providing. So the thing is, and the reason why I ask this is because a lot of people be like, oh, the provider, the doctor. You're a provider. You will be a provider. You can't just say like, oh, this is not going to be my problem. I'm going to write it, and that doctor is going to be responsible for it. You will be responsible too. And somebody, bless you, somebody made the good, everybody, the pharmacy is responsible, everybody is responsible. Because if you write the right thing and I feel the wrong thing, I'm responsible for that also. So we're all responsible for that patient care. The patient is also responsible. But ultimately, when we're talking about writing a prescription, you are going to be the one who is responsible for that patient. When they are in your care, you are responsible. Okay? What is a prescription? Can I'll let one of y'all tell. What is a prescription? Who said that? A written order for something. That is correct, right? So when we talk about a prescription, we're talking about something that you specifically order for that patient. Okay? Don't take all the candy, just get one candy. Okay? If you don't like candy, it's one pocket. It's just one pocket of candy. So a prescription is something that you are specifically writing for a patient. This will vary depending on what symptoms that patient has, right? So like, what is that disease state? You got to figure that out, because then you're going to write an order for that disease state. What side effects do I have, right? Am I experiencing side effects from the order that you gave me? I'll come and get it because I'm going to ask some more questions and we'll pass them. If I am not tolerating that med, you're going to have to write a different order. I can't just go to Walgreens and go over the counter and just get that prescription that you're giving me. Because some meds I specifically have to come and see you for, right? It's not like getting Tylenol, it's not like getting ibuprofen. You actually have to write a prescription. Sometimes you can write a prescription for something that is over the counter, but it is not required. The reason why some people do that is because they know that their patient might forget it, so they'll write it down for them. Or sometimes, especially with TRICARE, sometimes they will pay for it over-the-counter medication. Especially if you're getting it filled in the MTF, like we can fill over-the-counter medications and they don't have to pay for it. So like if you have somebody who takes Mucinex D, okay? Mucinex D is $1 gazillion over the counter, but it's an over-the-counter med, you don't need a prescription for it. But if you choose to write it for a patient, they can get it free from us. They don't have to pay for it. They're gonna have to wait in the pharmacy, but they won't have to pay for it, okay? So a prescription is essentially an order that you are given for that patient for a medication. Is a legend drug the same thing as an over-the-counter drug? Yes or no? This is just a we just feel it, we can blurt out stuff and get a safe spot. No, it's not. Okay, 50-50 chance, see? That's what I'm talking about, it's a 50-50 chance. So when we talk about a legend drug is something that is a prescription. You're gonna have to write a prescription for it. When you talk about OTC stands for over the counter, right? So again, those over the counter medications, I don't have to write a prescription for that over the counter medication. That patient can just go and get it and they don't need anything from it, okay? So what is an ADR? Kind of talks to y'all about this, or an adverse drug reaction, right? Something that the patient is having occur because they're taking a medication, okay? So I give them a medication, whether they're taking it correctly or not, I give them a medication and they have some type of reaction to it, okay? That's an adverse drug reaction. Doesn't mean that you did anything wrong, doesn't mean that they did anything wrong, that's just what their body chose to do to that medication. And sometimes, depending on what the adverse drug reaction is, you may have to stop that medication, okay? I give it to you. How many drug trial phases are there whenever we're coming up with making new medications? So there's 4 different phases that you have. 3 of them are highly scrutinized. We'll talk a little bit about different studies that we have, but there's lots of money that goes into studies. And we're trying to make sure that these drugs are safe. We're trying to make sure that they're effective before we put them out on the market, that they're doing exactly what they said they were going to do, okay? So that's the big thing when we're talking about our clinical trials and kind of how they work. And then there are several different ones of these. So we're talking about what are resources to help with drug dosing. I'm not going to make you guys remember doses, okay? There's very, very few drugs where I'm gonna say, hey, I need you to remember this. If I don't say, hey, I need you to remember this, you're not remembering them, okay? I don't need you to know those things because we're gonna look those up. You have LexiComp, which you can put on your phone. You can go to the library. It's not as easy anymore to download it. Up to date. If you have someone who's pregnant, that's why you see that LactMed there. It's also in LexiComp for you to see like if they're breastfeeding or not, or if they're pregnant also. But LactMed kind of helps you with if this medication is going to be in their breast milk, because some meds will go through the breast milk at high enough concentrations to where it could affect the baby. Okay, so that's where you can use your LactMed at. All right, writing the prescription. We already talked about this, the practice and the responsibility. All of these things are going to start falling on you, okay? It's going to be your responsibility to take care of that patient and to make sure that you're doing everything that you can to let them come into your office with whatever that problem is, and they're going to leave out of that patient room, hopefully, with you taking care of them and giving them a medication if they need a medication. Every single time that somebody comes into you, that does not mean that they need a medication. If I have a cold, that does not mean that you need a medication, right? Because it's a virus, it's going to go away. I don't have anything to give you for a cold. I don't need to give you an antibiotic, okay? And I could be the screaming mother. It doesn't matter. You're going to educate that person. You're going to be like, I'm so sorry. Do not understand that your kid is getting on your nerves. But what I am not going to do is give you an antibiotic, okay? So you talk to them, you work through it, and you let them know and educate, because some people don't know. They think, I'm sick, I need medicine, right? So what is a prescription? We already talked about this, right? It's that specific order. And then what you'll hear some people say sometimes is, oh, what's the SIG? That's just you saying, like, what are the directions that I'm going to put on here? Like, how am I going to label this medication, all right? And then you have the who can this prescription be directed to? So I could direct it to that patient. I could say, take, 1 tablet every day. If it's a child, I'm not going to tell the child to take it. I'm going to tell that parent, I'm going to say, give 5 milliliters every day, okay? So it can be addressed to several different people. You have patients who are in nursing homes. You have a therapist that could be administering that medication. So it could go to anyone. You can essentially write this order for anyone. It just depends on who's administering it or if that person has the capability to administer it to themselves or not. When we're talking about drugs, we're always going to talk about the safety and the efficacy of those drugs. There are several different things that have happened over the years that now have us have several different regulations to kind of guide what we are doing as medical providers, okay, healthcare providers. So when you look at the safety categories, we have the FDA, or the Food and Drug Administration, and they say, hey, this drug is easy enough to be given, it's not super harmful, this can be over the counter, versus absolutely not, they need to be diagnosed by someone before they take this medication. This is an RX or a prescription. So when you see RX, that stands also for prescription, okay? Versus OTC, which was your over the counter. And then you'll also hear sometimes while we're going through things, oh, this has a warning or a black box warning, okay? That's something that is very, very serious that could occur due to the medication that we're worried about for our patients, okay? So if you see a black box warning, that's a big deal. And that's something that we would typically say, hey, I need to warn my patient about this because this is a risk that could be life-threatening if they took this medication. And then our legend drugs, we already talked about those. And then our over-the-counter drugs, we already talked about those as well. And then looking at our abuse categories, when we talk about our abuse category, think of the DEA, right? So when you think about abuse, think about like opioids, our amphetamines that we have, like anything that someone could take and abuse it. Okay, those are usually going to be what we also call a controlled substance or a controlled medication. So think about your heavier pain meds. Okay, a lot of our heavier pain meds, some of our sleep medications, again, ADHD medications, a lot of those will fall under the DEA's purview because those are all called controlled substances. And then we have different schedules of that controlled substance, which we'll talk about a little bit later. Okay, so FDA is broad. It's saying, yes, this is a prescription, no, this isn't a prescription, okay? Is it safe, is it effective? And then when you're looking at like controlled substances, you're always thinking about the DEA, okay? Again, we talk about our indications. When we prescribe a medication, we want to make sure that we're prescribing it for the condition that that patient has. If you give me a med for a condition that I don't have, that's not effective, right? That's not good practice either, okay? So we gotta pick name the game, okay? So if I have this issue, you have to give me the drug to match that issue, okay? The FDA is the one who is saying, hey, this drug does this thing. It's gonna go through those clinical trials, it's gonna go through all of this research, and the FDA that entire time is saying, is this safe, is this effective? In several of those phases. They'll start with a smaller group of people and then it starts to continue to grow, okay? So that is the FDA's big job. Can people take this without getting harmed, all right? So you have different uses, your labeled use, and then you have an unlabeled or off-label use. Your labeled use is essentially what I went through the FDA for. So let's say I was making a new drug called Rena, and I said, hey, I'm gonna submit this NDA or a new drug application to the FDA because I wanna make my drug called Rena, right? I'm trying to say to them, hey, this drug is safe and effective, I know that it's gonna work. Rena is gonna make people happy. That's what Rena is gonna do, right? And so they're like, okay, that sounds nice. We're gonna put you through this whole clinical trials. There's labs that are gonna be involved. We're gonna get human subjects to see if when we give them Rena, they get happy, right? Safe and effective. An unlabeled use is something that I didn't get approved for. So let's say I went through that, all of my people in my trial, they were happy. It worked, great. That is my labeled use. Now my unlabeled use is the FDA did not approve me for using it for this, but I have found over time with practice, with research, that this drug can also do this as well. That's my off-label or my unlabeled use. I don't take the drug back to the FDA to prove it to them because I have all of these now research studies that are saying, hey, this does work for this. A good example, but they made a lot of money off of it, they went back to the FDA for it, was Viagra. Viagra was approved for stuff dealing with blood pressure, okay? And then they were like, oh, look what happens, it causes this erection. So they're like, money. So they went back to the FDA and they were like, hey, here's this new drug application, same exact medication. We want to call it this, and this is the indication for it. So now it is sold as Viagra. And now we get this money for this. Or they could have continued to use that same original med that they had off-label for erectile dysfunction. They're not going to make as much money that way. So they went back because they found something that people don't want to have, and they used it for that. Yes.
I'm just curious, when they're doing all these studies and stuff for label use, why can't they just say, hey, we found this and add it to the label instead of having to redo the whole thing? That doesn't make sense.
Yeah. So they can, which is usually how these off-label uses kind of come about. But when we're going through trials, you don't have as many people using something, if that makes sense. So like, I'm controlling, so like on the first phase, I may only have a couple hundred people. So it's not a good enough sample, so to speak, to be like, now I'm gonna add this. They will make you go back and do like an abbreviated, it's a lot of paperwork. And as a drug company, they're already gonna spend billions of dollars to bring a drug to market. And then you hope that it catches on. So that's why you see all those commercials and everybody's smiling and at the end they're like, make all kinds of and you're like, why do I want that? They're not, so like a lot of this stuff, when you think about it in marketing and money, it's a lot of the stuff deals with money and time. They want their drug to come to market as soon as they can. So the longer I do that, if I keep going back and modifying, then I'm delaying my time. This process takes sometimes up to 10 years. Typically 10 years for a drug to come from somebody's brain to where we're actually buying it. So most of the time, you're not gonna see them go back for a labeled use. We'll have off-label use. And this is one of the big ones that you'll see for that, yes.
What about non-prescribed drugs like Tylenol PM will have like Benadryl in it?
marketing, right? So I don't have to go back for that. Benadryl is something that's already approved. So whenever Tylenol does that, right? So Tylenol is a brand. I guess I shouldn't say Tylenol. So Tylenol is the brand of acetaminophen, right? So when we're talking about acetaminophen, right? You have also Benadryl, which is the brand. The generic is diphenhydramine. So anything that typically says PM on it has diphenhydramine in it. Diphenhydramine is already approved, so yes, those drugs aren't in combo, so they would go back to put, like, say, I want to brand this drug as mine. So now I want to call this Tylenol PM. So they'll go back through and they'll do that to put those two things together because they were separate. And maybe Tylenol brand Tylenol made this, but they didn't make the diphenhydramine or the Benadryl. So they will go back for something like that. They can't just like be like, oh, I'm gonna add that in, I'm gonna add that in. They can't do that. They have to go back through the whole process. Okay. So this is a big example of a medication that has a actual approved use, right? So gabapentin is something that you're going to be very familiar with whenever you start prescribing meds. So I don't need you to remember these. These are just this is just an example for you to understand the difference between an approved use and an unapproved use. I need you to remember the definitions of those, not anything about this drug right now. So when we're looking at this, essentially what we're saying is we use this for seizures, we use this for neuralgia, which is like nerve pain, and we can use it in adults and we can use it in kids for these indications. When you look at the unapproved or off-label use, you see that we can use it for patients who are going through alcohol withdrawal, right? A lot of patients who go through alcohol withdrawal, they'll also have seizures, they'll have some of these things occur, they'll have different imbalances that are occurring, so we use it there. Fibromyalgia, which is again some type of a different type of pain that they're having. GAD or generalized anxiety disorder, so we can use it for several different things. These are all off-label. You can prescribe off-label safely. You're not prescribing because I'm the doctor and I said, hey, I know that it doesn't say this on the label, but let's try to see if this works. Where is your research that shows that this works, right? Because you'll have some people who have been providers for a very long time and they have found that something does work off-label for a particular disease. But for you and your license, you will say, oh, well, let me read the research. And then if you don't feel comfortable or you don't see the research and the research is just with that one provider, then you say, hey, sir, ma'am, I don't feel comfortable writing that. Can you go ahead and do that? Put your signature on that because I can't find anything. There's nothing wrong with that. You are going through school for 2 years. This is going to be your license. Don't let anybody jeopardize your license except for you. Don't let anybody make you feel forced to do anything because you're not. It's your license, right? So don't feel forced ever to write a prescription for something. I hear it all the time about people saying, well, they told me to write it and that's why I wrote it. No. We had a patient who almost overdosed. Well, he did end up overdosing. But it was a soldier and he was getting prescribed cough syrup with codeine in it from a psychiatrist. Why, sir, are you writing this? Oh, well, because the patient said that he always has been taking it and I saw that someone else wrote for it. Well, that's outside of your scope. And if something happens to this person, it's now going to be your problem. Not the patient's problem, not the person who wrote it before. And I'm talking about he was writing for bottles at a time that looked like this. And I was like, we are not filling these. We're done. Okay? So you have to not be that provider or that person. Don't just look at a profile and be like, oh yeah, I see they've used that before. I'm going to write for it. Or, hey, I see this medication is typically used for this, but the patient is telling me they were using it for that. If you don't see research for it, you are not writing for that unapproved use for that. Okay?
And when you say research, like, is there like are you talking like websites or like things like is it hearsay from other doctors? Or like, I'm sure not, but like.
So you know how you have your PICO assignment, right? The reason why we're doing that is so that you can look at studies and you can say, is this a valid study or not? If I am the person who is funding something and I want you to use my drug, probably not the best study for you to use because I'm going to make sure that my results are great because I want you to come and buy my drug, right? So it will be you looking at different articles to say like, hey, is this, and a lot of times in Lexicon, it'll tell you the off-label use. So if you see it in Lexicon, they've researched it, okay? So you will see like the indications and then you'll see off-label kind of underneath it, okay? Or it'll give you different disease states, and then in parentheses it will say like off-label use. So I go to Lexicon, and then if it's not on Lexicon, I'll try to go through, I'll research it, and I'll be like, I don't feel comfortable, like you gotta do that. Or I want to approve the prescription, I'll be like, let me call the provider and see what they say, okay? So this is one of those ones where like, do your due diligence, but if you look on Lexicon, most of the time it's gonna be there. Let's go ahead and take our 10-minute break and come back and what time will that be? At 11. And who's your class leader? Oh.
But the good stuff. Oh no. I haven't heard that in so long.
Alright, let's get started in. Okay, when we're looking at our drug orders, we kind of touched on this a little bit already, but just make sure that it makes sense, right? Like, what am I ordering? What am I ordering it for? Does this make sense for what my patient has? Looking at your drug choice, you'll say like, okay, what dose do I want to give this patient? You can also look this up when we're talking about the dosing. Some drugs will be weight-based, so it will be based on the weight. So if you have a heavier person versus a smaller person, they may not take the same exact thing. There's some meds where that weight may not matter, okay? So like essentially just make sure that you're doing your due diligence before you order something to make sure that it matches that patient and what that patient has going on. And then what is the program? And did you get buy-in? You can prescribe whatever you want all day long. If you don't get my buy-in as a patient, I'm not gonna take your med, right? And so now it's sitting in a bottle or it's sitting at the pharmacy and I never picked it up, okay? So your job is to say, yes, I prescribed this medication. I got this patient to understand why they're taking it. They know that I'm gonna check on them in a couple of months to see that they're taking the medication, they're not having any side effects. We're gonna have essentially a plan for us putting them on this medication, how we're gonna put them on it. Some meds we have to slowly increase the dose, some meds we have to slowly taper them off of it. So all of that will be a part of your plan. All of that, you're gonna have to loop that patient in. So just making sure that what you're doing is rational, making sure that that patient is on board with what you're doing, because if they are not, everything that you're doing is a waste of time, okay? When we're talking about your writing privileges, okay, you will be able to write prescriptions. What you will be able to write will be determined by the P&T committee that is going to be at the installation that you are at, okay? So the P&T committee is called, is a pharmacy and therapeutics committee, and essentially it will have pharmacists on it, clinical pharmacists, it will have different providers from different areas in the hospital, and they will all get together and they will look at different medications and say, hey, like I want to be able to prescribe this in my clinic. I'm ortho and I want this new cutting edge medication. And then the pharmacy will go and they're gonna look at it, they're gonna look at how much it costs, they're gonna look at the efficacy of it, they're gonna say like, how effective is this? Like, do only 10% of people get it and it costs $1,000? We're probably not going to put this on our formulary, you will probably not be able to write for it. They'll probably make you do like a medical necessity and all these other things. So the P&T committee is essentially your gatekeeper for what you can and cannot write, okay? If there is something that you cannot currently write a prescription for, you can go to the P&T committee and say, hey, like I would like to write for this. This is why, here's my rationale, this is why my clinic wants to use this, and sometimes they will get approved. Okay, that's how we continue to allow our drug formulary to grow. And then when you're looking at this, we're providing the primary field medical support during a field training exercise. Understand that you will be the one who is typically responsible for the medications. And so whatever is in that set is what you will be able to prescribe for, okay? So sometimes you guys will get together, y'all will make a list with the docs, and y'all say, this is what we want in our kits. You'll get it through supply, and then you will be able to write for whatever is in there. If there are controlled substances in there, you will probably also be responsible for those as well. Which means when you go to the bathroom, when you go wherever, you need to make sure your stuff is locked up, because if they come up missing, it's gonna be on you, and it's not gonna be fun at all, I promise you. We had that happen in our pharmacy. We had somebody who was taking some of our scheduled medications, our pain meds, and CID came in, 15-6 was done, it was a whole thing, okay? So just make sure if you are downrange or you are even at like any type of training exercise and you have any like narcotic medications, that you and somebody else who you trust that you're appointing to be over that box that you're gonna have, that y'all are keeping a close eye on it, okay? Hopefully we don't have anything happen when stuff happens. Very rarely now will you have prescriptions that are written. Most of the time we're going to be using Genesis, okay? Computer goes down. We do have what's called 1289 forms that you'll have to go to. Sometimes, it depends on where you are, they store these in different places, but sometimes CAD has these and they will have to issue them to you. You're not supposed to just go on the internet and like print out a 1289, okay? They issue them to you, and essentially what you would do with this is you would use this to give someone a paper prescription if Genesis was down. If Genesis is down on your side, it's likely down on the pharmacy side also, okay? But if you give this person a paper prescription, they can go to Walgreens, CVS, wherever they want, and they can get that prescription filled, okay? So that is a way around it. If they're like, I need my medicine right now, then you can be like, okay, let me whip out my 1289s and I can write a prescription for you, okay? So that's the use of this. Don't write this and tell them to go to the pharmacy and we can fill it, because we probably can't either because our system is down. There are some places where we do take these. So like where I developed a plan for when our systems got knocked off of Genesis, or then it was CHCS. that we would print out paper labels, label the medication, we still filled it, and then when the system came back up, we typed in all of these and scanned all of these for the patients to still be able to get their meds. But it's a little bit different, it depends on where you are, where we may or may not have like a downtime backup plan. All right, this is important for you to know because you need to know if you do have to write a prescription, what goes on it, okay? You need to make sure that the patient's full name is on the prescription, all right? Who are you writing this prescription for is important. Then you need to have the name and the strength of the drug, the quantity, right? How many are you gonna give me? The directions, how am I supposed to take it? And then the number of refills, okay? There's several different things that are listed on here as you see. I want you to focus on the ones that are in pink because these are the real life ones that like, I need to know these things. And if you think about it, it makes sense, right? Like who is it going to? What are you giving them? How are you giving it to them? Can they get more or not, which is your refills, okay? The date is very important as well because prescriptions expire. Depending on if it's a control or not a control, the time that it takes for which it expires may vary, okay? So the date on the prescription is also very important, and you have to write that. When you're looking at the signature, that is you saying, yep, this is what I want my patient to have, and you're signing off on it. Please make sure that you write in ink when you're writing prescriptions, because if you don't, and I'm drug seeking, maybe, I don't know, and you gave me 10 Norco and I wanted to go in and make it 100, that could be a big difference, right? So like write in pen, and then we'll also talk about controlled substances where you're not only gonna write number 10, you're gonna spell out 10 too. Because that way if somebody tries to change your 10 into 100, now they're gonna have to make 10, T-E-N, somehow look like 100 without being written over crazy, okay? So that's why you're always writing in ink. We had a patient who used to do this when I worked at Walgreens, and he came in, and I told the pharmacist, I was like, man, I feel him. I feel like I saw him every day this week. But the prescriptions would have different people's names on them all the time. And I was like, I'm pretty sure this is the same person with the same card. And he was always very, like, overly nice. So that's why I remembered him, because most people who come to the pharmacy, they're not nice to you. They're usually overly. And so I remember him, and we filled she was like, should we call the police? That's what I said. I said, should we call the police? And she's like, we're going to fill the prescription because the police won't do anything unless he actually comes back to pick it up. And so I was like, okay. So we filled the prescription with Skittles, and we put it in a vial. I labeled it and everything. And I was like, can I have the leftover Skittles, please? And so we filled the bottle, and the person came back to pick it up. He got arrested in our drive-thru, and it was very entertaining. But I felt very bad for the person because I was like, man, he got away with it all week, and like he's going to come back and he's going to be mad at me. But I'm going to be like, I have no idea what you're talking about because I sold him Skittles. But please make sure that you're signing it. What that person did was he stole the doctor's prescription pad. And because it was him who kept writing the prescriptions, the signature looked the same. But then I just so happened to remember his face, okay? So don't leave. If you have 1289, don't pre-sign things, okay? Because people steal prescription pads all the time. And then they can just write out whatever they want with your signature, with your license, okay? So we had to notify the doctor. The doctor was aware because the amount of narcotics that he had been dispensing had increased greatly because that person had continued to write prescriptions. And he wasn't just filling at our Walgreens. He was going to CVS, like he was going all over and paying cash so that the insurance wouldn't reject it. So if you pay cash, nobody sees it. Now we have a way around that. Down here with the notes, if someone is less than 12 years old, please, 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 it is the best thing, a great practice for you to put the weight of the age of the child on the prescription. The reason why we do this is because a lot of pediatric medications are weight-based. So we want to make sure that we have the most up-to-date weight because sometimes on our system, it doesn't give us the weight that you just got from that child sometimes. And sometimes it's a different screen for us. So if you could just put it in there in the notes, it makes it go a lot faster for us because we will check your math to say, hey, did they calculate this right? Okay? So if that weight is there, it's already easier for us to do that. Controlled substances, I already told you, you'll numerically write out that quantity and then you're going to also spell it out so that way we can try to prevent any type of fraud from happening. And then a DEA number or an NPI must also be on any prescription that you write as a control. When we talk about a DEA number, remember we said the DEA is over all of those controlled medications, right? So when we're looking at this, you have to have a number that is registered with the DEA for you to actually write controlled medications. You'll go in, bless you, you'll put your license number in, and then they give you back like a DEA number. Same thing with an NPI number. You have the NPI numbers that should also be on the prescriptions as well. And then you see the 1289. The only thing with our 1289s, which is different from the civilian side, is your 1289s, you can only write one drug per paper. So if you're having 5 prescriptions that you want to give me, you need 5 1289s. On the outside, you can write several different drugs on one prescription pad, okay? But here, for DODY, you should only have one drug per 1289. If you're practicing on the outside, you can write multiple on your pads. All right, our drug name classifications. When I was talking to you, I was telling you about a brand and generic. But when we're doing like new drug applications, things like that, you'll see a chemical name. We are never going to use a chemical name. We're not going to talk to y'all about a chemical name. We're not biochem it, okay? You will see this if you're looking at like the FDA application. You will see this if you're like looking in a package insert. You'll see the chemical name, but it's not something that's really used, okay? Your brand name or the trade name is owned by that company, okay? So they have a patent or a proprietary name that they're exclusively using for that generic drug. They branded it so that it is theirs, right? So they are the only ones that can use that name. So when you see Motrin, Motrin is what drug? Does anybody know? Ibuprofen, right? But Motrin is the brand name. They have patented that name to where they can say, I am Motrin. And then I can come as Walmart and say, Walmart, ibuprofen. Still the same drug, but the brand name that we all know is Motrin, just like the brand name for acetaminophen is Tylenol, and we all know Tylenol. But you can still go and buy acetaminophen, same thing, okay? The patent, these are good for 20 years. So therefore, if I am the first one who came out with ibuprofen, and I said it's Motrin, no one else can do that for 20 years. I own it. And then after that 20 years, then that's when Walmart and everybody else can come out with their own brands of ibuprofen. Your generic name, this one again is just like the one that's not trademarked. Anybody can use it. Nothing special. It's not like they had to change the chemical structure of it or anything. It's just that is the generic name. This is what you will be tested on your pants. All of your drugs will be in the generic names, okay? Your categories. So when we talk about a category, this is just saying like, hey, this drug falls under this drug category. So you'll hear me say like, it's this category a lot. So if we talk about a non-steroidal anti-inflammatory drug or an NSAID, I could be like, ibuprofen is an NSAID. It falls under that category. That drug, ibuprofen, falls under an NSAID category, okay? Just so you can remember the terms, because as we go through it, it kind of gets difficult. And then looking at your target system that you have, so this is just essentially telling you like the mechanism of action, all right? So how does that drug work? What does it do? That is the breakdown essentially of what you're going to see as we continue to go through this semester. It's like a lot of the MOAs and things like that. Your quantity is essentially how much you're giving that patient, and then your directions or your SIG is that, like how am I using it? So when you're looking at your prescription quantity, make sure that you're prescribing enough for whatever that condition is, right? Was this something that was acute that happened to me, or is this something that is going to be chronic, like high blood pressure that I'm going to always have regardless of what's going on? If it's something that is maintenance treatment, I can prescribe more versus I slam my finger in the door and I only need something to help me with swelling for maybe a week or two, or my pain for a week or two, right? So don't give me, I was gonna say 90 of ibuprofen, but that's always what we give. Don't give me 90 Vicodin, okay? Don't give me 90 of hydrocodone to say like, here, take care of this finger that's probably gonna hurt me for a week, because now I have a lot to do fun things with. Just kidding. So don't over prescribe is what I want you to remember, okay? prescribe it for the amount of time that they need it. And then, have they used it before? This is an important question because if I am naive to something, I've never used it before, I might respond, I might be more sensitive to that medication. So think about a person who's never had like a drink before, or somebody who has never like smoked nicotine or anything like that, right? And they do it for the first time and like it's like, whoo. But that person who does it all the time, they're like, oh, you're a lightweight. It's the same thing with like drugs. These are medications, right? So that first time that I use it, I may respond very like sensitive, like it may hit me a lot harder and I'd be like, oh, okay, like this is a lot. In some of our meds, when we get that feeling, we might say, okay, we need to change the dose. Or some of those meds we may say, all right, they can't tolerate this at all, we need to get them off of it, okay? Some meds we may say, I understand you feel like that, give it 2 weeks and this will wear off. And that's sometimes what happens. Most of the time that's what we do. And then if it's something that's like pain, a lot of the times we'll have that patient come back to visit us to say like, are you still in pain? All right, do we need to prescribe more physical therapy right now? Like what else can we do besides continuing to refill these pain meds for you? Okay, so some of your medications, you're gonna follow up with your patient to say, do I need to keep giving this? Is this something that is a maintenance med that I need to keep them on for a long time or not? Okay. Don't be afraid of pain medications either. I know I'm picking on pain because that's the easiest one. That's what like makes the news and like everybody hears about. But some people are really in pain and they really do need medication. Okay? Don't be afraid to actually treat your patient. We had somebody who had a broken arm and they gave them ibuprofen. And I called the doctor and I was like, are you kidding me right now? Like this person is in here crying and you gave them like arm and they hadn't cast it yet. So that also was probably even more painful because it wasn't as stable and they just gave ibuprofen, 90 at that of ibuprofen. And so just again, is this appropriate for what is happening? Always look at that, okay, for that patient. And then your directions, make sure that they're clear, concise, that the patient understands it. Tell them while they're in there with you. You will reiterate it when they come to the pharmacy. They're gonna get home and they're gonna do whatever they wanna do anyway, okay? That's usually what happens. I had somebody call because they were saying, I can't swallow this med. And I was like, okay, name, date, birth, look it up. They were trying to swallow a suppository, which said unwrap and insert rectally, and they were trying to swallow it, okay? So, please, just try. All we can do is try, but tell people what you want them to do with the medication that you're gonna prescribe. Don't just say, like, I'm gonna give you something, and then you go pick it up from the pharmacy. Tell them so that they know what to expect because sometimes we may make a mistake also. And then that patient could be like, wait a minute, my doctor said that I was supposed to like take a puff of something and you gave me a pill. Or you gave me something that you're telling me to insert rectally, but he said a puff. Like how I might have puffed that. Okay? So it's like, make sure, that sounds like puff, never mind. Make sure that you are keeping track right and you're keeping the patient in the loop. Okay? Clear, complete, concise, go over it with the patient, and then we'll try to go over it with the patient and make sure that they understand what you're telling them to do, okay? Avoid putting take as directed. There are very few medications that we have where you can write that because on the box, like the actual box that we'll give the patient, it has the directions written out for them. So a good example of this is methylprednisolone or a dose pack for a steroid, corticosteroid. And so it has on there, take before breakfast, take before lunch, take after this time, take before bedtime, take at bedtime. Like it tells them everything to do. They will still probably pop them all out at once, which is the common thing that we see, and take them all at one time. And the words are right there. So even if you have a package that is like that, go over it with your patient and say, hey, it's gonna tell you what to do on the inside of the packet. That's why this says take as directed. But follow exactly what it says on the inside of the packet. We tell them to, we take it out, I show them, and they'll still be like, I took them all at one time and my stomach hurts. Yes, it does. That was a lot, okay? You just gave yourself a burst of steroids. It does hurt. So, make sure that you are, again, just looping them in. Refills. They're coming up again because this is important and you're gonna see where your refills matter. Some providers, they won't put a refill, like the number of refills that's on the prescription. So for the pharmacy, we assume that means 0. Okay, we don't see anything filled out for a refill, they don't get a refill. That means that they're getting it one time. When you talk about states, in most states, they can have a prescription and the prescription lasts for a year, okay? So that's why it's important for you to put that date on the prescription. After 1 year, they have to now come back to see you for you to write them another prescription. If they do not get another prescription, they do not get a refill on that medication, okay? So when we talk about controlled substances, our refills now are gonna be different, okay? Because my controlled substances, I'm looking at these a little bit more because the DEA is watching, okay? So I'm not gonna be able to freely get refills when I'm talking about my controlled substances. So you have what's called Schedule 1 through 5, but Schedule 1 drugs are like research drugs. You won't be prescribing those, you won't use those unless you're in research. But then you have like your Schedule 2 drugs. Schedule 2 through 5, you will prescribe these quite a bit. So your Schedule 2 drugs, these don't have refills. No matter what, they don't have refills. Now the quantity can vary on these Schedule 2 drugs without refills. If it is a maintenance drug, you can write them for 90, a quantity of 90, or depending on how they're taking it. Most of the time, this includes like ADHD medications, but it will still have 0 refills. That quantity will last them for 3 months. Okay, so that's why I say depending on how they're taking it. If they were just taking 1 a day, then that would be 90. But if they're taking 2, then 1 a, because sometimes depending on what med and how the person is dealing with their ADHD, they may take it multiple times throughout the day. So no refill Schedule 2, right? Our Schedule 3 through 5, these are good from 6 months from the date that you wrote it, or they can have 5 refills within that 6 months. So they have 2 constraints, right? After 6 months, that prescription is null and void, but they can have up to 5 refills. So if they have 5 refills plus the original prescription that you gave them, so I have 5 refills and then that prescription you wrote, that means I get 6 months of medication, essentially, okay? The one that you originally wrote and then my 5 refills if I come every month. Now let's say I got the one that you originally wrote and I said, oh, I don't need it next month. And then I skip that month. And so now I still have those 5 refills. But let's say my 6 months comes up first, right? I forfeit whatever I did not get. So now I may only be able to get 4 refills on that prescription because I missed that 1 month, okay? So they may come back to you even though they didn't get all of the fills. They may just fill that one and say, oh, like I didn't need it. We see this a lot with like anxiety medications. They'll say, oh, like I didn't need it, or sleeping meds. Oh, I didn't take it every night. And so they'll come and they'll get their 30-day supply, and then they'll skip a couple of months, and then they'll come and pick it up again. They'll skip a couple of months, and it's like, oh, well, you need a new refill. Okay, so you need to go back to the doctor. So you'll see that happen. So a maximum of 5 refills within that 6-month period. If the 6 months comes and they haven't used all those refills, they just forfeited them. They go away because now the prescription is expired. Okay? How many refills on our Schedule 2? No. All right. Medication errors. Make sure that you write so that we can read it. Pharmacists, we're all right. We're good people, but we're not detectives. I'm a detective, but we're not detectives, okay? So when you write and it looks like this, we're a little angry. Like, who is the prescription for? What is the medication? This is a medication error waiting to happen, which is why we have a lot of states that say you have to electronically now send over prescriptions. So that way we avoid this. We avoid having this illegible handwriting. So with this one, this was supposed to be a medication. They filled it, they thought it said Plendil, and it was supposed to be Isordil, which you don't see that at all in here. So like, just please, 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 if you have to write and you know that your handwriting is not fantastic, then you can also get someone else to write it as long as you sign it. Not the patient as someone else. You can get an agent, somebody that works there with you to write it, and then you still have to sign it. They can't sign for you, but they can write for you, okay? Compliance. This is a big key because you can do your part, but the patient can decide they don't want to do their part, right? I'm not complying. I don't want to follow the instructions that you gave me as the provider. okay? So that's why I say a big part of your job is gonna be that buy-in, talking to your patient to make sure that they understand what they're supposed to do so that they can get better. And then those lifestyle modifications as well, so that you're not continuing to try to increase a dose. There's several ways for that patient to become non-compliant. They don't have to pick up their prescription. They can take it incorrectly. You see all of these different things there. Antibiotics is a big one with this one where they'll start to feel better and then they'll say like, oh, I feel better now, I don't need to take it anymore, okay? And then they stop taking the medication prematurely. It says for 7 days for a reason. I don't ever hear that often in class. All right, and then the factors that increase or encourage non-compliance. And this is worded kind of just weird, but like, think about this. If you're not taking something every day, you're likely to forget that you have to take it. So if you're writing something that someone has to take like every other day, make sure that you write the days that they're supposed to take it. Monday, Wednesday, Friday. Take it every Friday. If it is one of those things where they're not taking it every single day. Also, if they have a med that they're supposed to take like 5 or 6 times a day, who's realistically gonna do that, right? So you're gonna pick a drug that has less frequent dosing. It's better for the patient. If they have something like hypertension, which is one of those diseases that they can't really see, especially if they don't feel bad, they're asymptomatic. That's what asymptomatic means. If they don't feel bad, a lot of people are like, well, why do I need to take the med? I only found out because I went in for a checkup, I'm fine. Okay, so those are the patients where you're gonna see they're likely to end up in there with more serious diseases because they don't feel the need to take the med. So again, the conversation, the education piece that you provide is more important than the actual med sometimes. Because sometimes the medication won't make it if you don't convince them that they need it, okay? All right, medical abbreviations. I need you to remember them. I'm not gonna read them to you. I'm gonna pick out a couple that kind of stand out. But these are things that you're going to see abbreviated that you're going to write whenever you're writing notes. It's essentially like our shorthand, okay? How can I write something faster to communicate with the pharmacy, to communicate with another provider on what I did? So even when you're writing your clinical notes, these are some appropriate abbreviations that you can use when you're writing out prescriptions or again, those notes. To your right-hand side, you'll see different types of bags that we typically carry in the pharmacy. So when you're doing IV, sometimes you can do fluid resuscitation with some of these injections, different things like that. Your D5, and you'll hear us say these things as we're going through. I don't use them as much, but you're gonna hear a lot of this in other classes. LR for your lactated ringers. So again, just abbreviations. The way that this looks for an exam is you have a question and I may be like, all right, I can write it in all shorthand. Or I can really spell it out and tell you like, hey, what's the shorthand answer of this? Okay, what does the abbreviation answer look like? All right, I'll show you an example of it. These are your measurements, okay? So liter, milliliter, notice on your milliliter that L is capitalized so that we don't have any medication errors with trying to read it. So make sure that's a capital L when you're doing that. And then looking at your different measurements that you have here, please also remember these conversions because you're gonna see these again when we talk about calculations, and those will not be given to you. What is happening outside? It's something serious. They're still going. I expected it to stop. So these you're gonna have to remember, especially when we're talking about calculations, because you're not gonna get the equation for it. So it's not gonna be like 1 teaspoon equals 5 mLs. Like it's not gonna tell you that. You're gonna have to know that that equals 5 mLs. Same thing when we're talking about like converting from a kilogram to a pound. You're gonna need to know that you have those 2.2 pounds in a kilogram. So when we're converting, you know how to convert that, okay? But the kilogram one is a big one, you're gonna see that. I'm gonna tell you that right now. You're gonna see that on your exam because it's gonna be a part of the calculation. You have a patient weight, you're gonna have to get them from their kilograms to their pounds. Very likely, okay? Dosage forms, this is just letting you again see different ways for you to write these dosage forms. When you see any of these on your right hand side, control release, sustained release, long acting, these are meds that a patient will likely have to take less frequently, okay? So if I see something that's long acting, I may have a regular medication that I have to take 3 times a day. But if I have a long acting, I may be able to just take it 1 time. or sustained release, I may be able to take it just one time, okay? If somebody's having a lot of adverse reactions, or they're saying like, oh, I have a lot of GI upset whenever I take this med, we have some medications that we put as sustained release so that it's now released over a slower period of time, and therefore we can decrease those side effects that they're experiencing. This is looking at all of your different routes of administration. Just again, look at it, NPL, nothing by mouth. Look at your your OD and your OS so that you can remember versus OU for both of them, so you can kind of remember what goes where, okay? Because if you get one of these, I could say like, oh, what's right eye? It could be something just as simple as that, and you're like, oh, here's the abbreviation for that, okay? This is our timing of administration, so you'll see these a lot, and this is, we see them in the pharmacy a lot because whenever providers put in their orders, they'll write it this way, and then we'll go ahead and we'll take the shorthand out and spell out the long way for you. Sometimes the system will automatically convert it for you, also whenever you put in the abbreviation. So just looking at this, PRN as needed, all these other ones, they're kind of, they make sense. Every is you just using a Q, so you can be like every day. QD is not something that we are supposed to use, which would mean like every day. That is not an abbreviation that we should be using, but you will see it. Just try to refrain from it and make sure that it is actually what that person meant to communicate. If you do see QD, that'll make more sense whenever we're looking at it right here. So you see how QD here for once daily. QD is here for once daily, and again, like, not an abbreviated, an approved abbreviation that we should use, because it can be, like, sometimes when people write a period, you know how they may do like this, like it's kind of like a circle. So some people may interpret it and they may think that it says every other day. And so that's why we're not supposed to do that. But I'm telling you, in real life, you may see that, okay? So just be aware and ask the other person if that is what they meant, and you just make sure that you don't do it. For the exam, you should never see that. If you see that, you're like, oh, that's the error. That's what's wrong right here. Okay. So these are all abbreviations that could be potentially used, but these are harmful to our patients. So what I want you to remember from here is the abbreviations that are not that are on the not to use list. Okay. And then this is what you should be writing. All right, you gotta write it out, essentially. Don't worry about the potential problem. I don't need you to remember that. I just need you to remember, hey, I can't use this. This is what I should do instead. Okay? Don't worry about the potential problems. So this is just an example of what this would look like. I know on your slides you should have these in here. So this is just kind of telling you like, all right, I could give it to you this way, and then you would say, all right, this is what I'm gonna do. This is what you're telling me. Insert one suppository rectally, or you could say per rectum, every 6 hours as needed for pain. Okay, apply to the affected area 3 times a day for 2 days. So this is like the shorthand versus you having to sit there and write out all of this. Okay? And then this would just be if you were doing it the other way around, right? So if I wanted you to write this shorthand, I would be like, all right, how do we do this? So 1 teaspoon of Robitussin every 4 hours as needed for cough. Take 1 teaspoon every 4 hours as needed for cough. All right? So just understand all of the abbreviations that we talked about, and then you'll be able to kind of go through those motions. Looking at our adverse drug events. When we talk about an adverse drug event, an adverse event is essentially anything that happens that is because of a drug, okay? It doesn't necessarily, I guess I shouldn't say, not say a drug, because of like anything medical, okay? The drug may or may not be the cause, and the drug could be potentially used in the proper way or the incorrect way for an adverse event to happen. It doesn't mean that something was done wrong, okay? So anytime you see like an adverse event or like an adverse drug event, you shouldn't automatically be like, oh, who did it and it's wrong. Also, remember when these happen, you can report them and they're supposed to be anonymous. You're not penalizing anybody. You're like, all right, where did our system fail and how can we improve it? Okay? So if this does happen, don't be embarrassed, even if it's you. Like, you can say, hey, this is what happened and we expect for them to be reported. And then the pharmacy and your department kind of reviews it and say like, hey, what can we do better to make sure that this doesn't happen again, so that this doesn't get to a patient and harm the patient, okay? So it's not supposed to be something that has any information about like, I put this in, I typed up the medication and you're just saying like, hey, this is the error, this is what happened, this is where I think it failed, okay? So when you look at the adverse drug event, this is something that we are saying is caused by a medication. Like, we now know, hey, this is from a medication that happened, okay? Versus my adverse event is like, it could be anything medically that has happened. This is saying the drug has done this. Whether it was used properly, like I had an adverse effect, or improperly, like I overdosed on the medication because you gave me too much, okay? So, adverse drug event. When we have an adverse drug event, it depends on what caused it. Sometimes we may have to stop that agent. Sometimes we may have to change the dose of the agent. Sometimes we may need to put that person on some type of supportive treatment because we damaged them and we can't reverse it and they may pass away. Sometimes we may have to wait for the medication to wear off in their system. So we just support them until that medication wears off. Sometimes we might have an antidote and we can give that antidote to reverse what we did. So there's several, or the patient did. So there's several different things that you can look at here as to what could happen and then what we may have to do in response to what happened. Okay, so big thing here is just make sure that you're being aware because sometimes we can have adverse drug events that kill people. Okay, it's very expensive. It's hard for us to sometimes, especially when it was something that was done wrong, to justify it. And it's hard mentally on the person. So just make sure you also, if somebody is involved in an ADE or even an adverse event, that you check on them also to make sure that they're okay. Because nobody ever wants something to happen while, like, on their watch, okay? Adverse drug reaction. With this one, this is caused by that medication. And again, this could be because, well, the medication is used properly, right? So I just couldn't tolerate that medication. Okay, there was nothing done wrong here. So you gave me an antibiotic and I broke out in hives. There was nothing done wrong. There was no way for you to know that before you gave it to me. I just had an adverse drug reaction. You gave me a medication and now I have migraines or headaches. That was just a side effect of the medication. There was no way for us to know. Your medication error, this is what gets us, right? This is us doing something incorrectly, whether it's the healthcare provider, whether it is the patient, because the patient can sometimes cause these things to happen as well. But this is something that is preventable, that could potentially lead to death, and it is because they use this medication inappropriately, and it caused that patient harm. There's different levels to our medication errors, some of which could be like, oh, like it didn't reach the patient, but we caught it, versus ones that reached the patient and like they almost died, or it reached the patient and they did die. So there's several different levels when we're talking about our medication errors. What I want you to understand is that these are avoidable things that we could do our due diligence to potentially prevent from happening, and it costs us a lot of money. And sometimes it costs people their lives. So this money, this estimated cost is $42 billion yearly. Lawsuits, right? The supportive care that we're having to do, the amount of personnel that it's going to take, the other people who are now waiting on all those personnel who are tending to the person who we had this medication error occur. All because we failed in our system somewhere, or our system had a gap somewhere that we didn't know, okay? It doesn't always have to be a malicious thing, right? Sometimes it's just an accident. An allergic reaction, hypersensitivity essentially occurring to a medication. You may not know ahead of time. They took a medication, or like, it's just like if someone ate peanut butter and then all of a sudden you look at them and they're all swollen, right? Like, you didn't know that they were gonna have an allergic reaction to it. The same thing happens with some of our medications. You don't know that they're gonna have an allergic reaction to it. You can desensitize the patient, so give them like micro doses. Usually I would send them to immunology for them to do that, not you, because if something does happen or they still can't tolerate it, you don't want that to be on your license either, right? Because then I have an anaphylactic shock, and then that's a bad thing. So anaphylactic shock is usually, if you catch it in time, the patient is okay. It's just not pleasant. And that is our serious adverse effect that we're worried about. That is a serious allergic reaction where their throat starts to close, their blood pressure drops, and they can die. And so when you hear me say, but did you die though? That is anaphylactic shock. Yes, I almost did, right? If the person tells you that that was their allergy to a med, you are not going to give that to them. You're going to be like, oh, okay, well, you're allergic to penicillin for real. You almost died though, right? Real life reaction. Versus someone who's saying like, oh, I had diarrhea. You just went to the bathroom, like, you're all right. This is all we have. I can treat you with this. But if that's the only med that you have to treat somebody with and they had anaphylactic shock, now you're kind of stuck, okay? And you're gonna need more help. I'm not gonna give you patients like that. But in real life, that is essentially what happens. So if a person comes across you and you see an allergy in a patient chart, if it doesn't tell you what their reaction was, ask the patient. And if the patient doesn't remember, ask them like, hey, do you know if anyone else in your family remembers exactly what happened? Like, did your throat close? Did you have issues like breathing? Most people will remember that. If they say yes to that, then you're steered clear, okay? And then your idiosyncratic reaction, this is that G6PD that I was talking to you about. And essentially this is like a genetic thing, right, that happens. In the military, we should all have G6PD testing done. Because a lot of our deployment meds, you can't take them if you're G6PD deficient. Essentially what will happen is their blood vessel or their blood cells will explode, okay? And so they're tired, they're short of breath, all these things. And we should all have this on file. So if you're looking or you're prescribing a drug and you see that G6PD is a big thing, go to their chart. If you don't see it there, you need to send them to get tested before you prescribe the medication. Sometimes we find out about genetic things after the fact. But there's very few drugs that we have where we'll say, hey, test beforehand because this could be very, very detrimental to your patient, okay? Adverse drug events, you have your MedWatch program, so if something happens to your patient, they come back to you, you go on here and you just report that adverse drug event, and then the FDA, they put it on the website to see if like a lot of people start getting that adverse drug event. This is how eventually sometimes meds may be pulled from the market. This is how we can also update package inserts to say like, hey, yes, in the studies when we had these couple thousand people, like it wasn't that widespread, but now that we have it out, people are starting to experience this. This is where you would go to report that, FDA MedWatch. All right, our controlled substances. Let me see let's try to get through this before. So you have a Controlled Substance Act of 1970, and this is where we decided, all right, we're out of our hippie era, right? Like we need to classify these drugs. We need to make sure that we're monitoring these drugs. And who monitors our drugs, our controlled drugs? DEA, right? So this was us classifying them as controls. We have our 5 categories, so you have your schedule 1 through 5, okay? And then this is any of those things that could be included, so the controlled substance is any drug that falls into that schedule. And then you have your DEA, and that's who's responsible for monitoring all of our meds that we have within this Controlled Substance Act, okay? So anything that falls in the schedule 1 through 5 is monitored by the DEA. So whenever you prescribe those, the DEA knows that you're prescribing those, okay? What determines the control of a medication, or what determines the schedule of a medication is typically us looking at the abuse potential. Like how likely is this medication to be abused? If it has a high abuse potential, it is typically a scheduled drug. And by abuse, it could be like making other illegal drugs. It could also be like I'm now addicted or dependent upon this medication to function, okay? Or it has some adverse effects that are desirable to people, so therefore they may abuse it. Like some of our controls or some of our Adderall, things like that, it'll make people lose weight. So some people will abuse it because they want to lose weight, right? You have testosterone that we use for people who have low T, but we also know that that can improve your athletic performance. So that is a controlled substance because that can have that be abused, okay? If there's any type of risk, anything like that to public health, you're probably going to see that it is a controlled substance. Commanders at installations also have the ability to say, I want this medication to be a control. So for instance, Viagra. Viagra is a controlled medication here. It was a controlled medication when I was at Fort Bliss. Okay? We keep it locked up in a safe. We have to do counts on it. The patients have to sign when they pick it up because the commander said, hey, this needs to be controlled. We don't want people to just walk around with their Viagra. Okay? And then we have all of our different classifications. So you've been seeing Schedule 1, we talked about Schedule 2 through 5. What I want you to worry about is just the schedule, okay? What is the schedule? So just this column. And the fact that, like I just told you, highest abuse, and then it starts to go down, right? I don't need you to remember examples, but for an example, heroin is a Schedule 1. You should not be seeing that. You should not be prescribing that. If anybody is using a Schedule 1 drug, they're probably in trouble, especially if they're in the military, okay? These are not things that we will use. MDMA, right? These are things that you'll see for research, or you'll see that these are just like illicit drugs that they don't have a medical use that we typically would use them for, okay? And then when we're looking at our prescriptions for our controlled substances, we already talked about the fact that you need to date them, you need to sign them, all of the specific things that I told you on that label with like your name, the DEA number or the NPI number. When you're writing out the refills, if you want them to have refills, make sure that you're putting those on there. Also, make sure that if you're writing out the quantity, the number, and then you're spelling out the word. I also, on the refills, it's very hard for them to forge this, and this is why people don't write out the number, like they write number 1 for a refill, because if they put 10, right, clearly you can't get the 10 in 6 months, right, if you were giving them a 30-day supply. But let's say you only gave me 10 of Xanax, and you only wanted me to try that for, a short period of time. Maybe you gave me that 10 for a month, and then I wrote a 0. I could technically, after 10 days, continue to come back every 10 days to get more, okay? So it's not a requirement, but if you don't give a full, 30-day supply of something, or give them the full 5 refills, I would write it out. For the exam, you are not required to write out the number of refills quantitatively and numerically. Only the quantity of the drug, okay? But for practice, for your protection, so that you know what you're dispensing, if you write a refill, number 0, 1, I would spell 1, 2, 2. I already told you this, in ink, and then that somebody else could write it for you. And then looking at our Schedule 2s, I already went over this with you as well, making sure that they're written, signed, they're legible if they are written, and that if it's a maintenance medication, you can have how many days? 90. Can you have refills? No. Okay? If it's not a maintenance medication, then they only get that 30-day supply. Okay? If it is a maintenance medication, you can give them 90, they still have no refills. When we talk about this federally, there is no time limit, but states can always be stricter than a federal law. Okay? And most states will say, in the state of Texas, they only have 30 days for a controlled medication to be filled from the date, 28 days, from the date that it was written. So if you wrote for Adderall, let's say in, what month are we in, August? Let's say you wrote it in June, and I never went to drop it off. In the state of Texas, they're like, well, this prescription is void now, and you have to go get a new one. It's expired, because it was only good for 28 days. So a state can choose to do whatever they want. A state can have a certain pad that it has to go on. Like Florida, it was on a regular piece of computer paper. We had lots of people coming to Florida to get meds. They were just typing up prescriptions and signing them. Here, it has a green paper that you have to get from the state, and it, again, 28 days. And it has this, you can't duplicate the pad. And you knew if it was you can't make a copy of it, okay? So a state is allowed to be more stringent if they choose to. We will pick up here tomorrow, and then we're gonna do calculations also tomorrow.